This is a follow-up presentation to mechanical ventilation. A pneumothorax is one complication of mechanical ventilation, known as barotrauma, so let's dig in. Before I get started talking about chest tubes, it is probably a good idea to talk about what occurs to a patient that a chest tube would be warranted. We spoke in class about the negative pressure in the intrapleural space as compared to the intrathoracic pressure. The intrapleural pressures should always be 4 millimeters of mercury less than the intrathoracic pressure, or there will be pressure on the lung itself, with ultimate collapse. The intrapleural space holds only a very small amount of fluid normally, usually around 2 to 10 mLs, so maintaining that negative pressure is not difficult until something enters that space that doesn't belong there. What can enter the pleural space can happen from an internal source as well as an external source. Internally, it could be air or blood from a pneumothorax. A pneumothorax can occur spontaneously without a known cause, or it can be caused secondarily due to emphysema and bleb formation, cystic fibrosis, or barotrauma, for example. Along that line, it could be from an external source due to an open pneumothorax. Internally, fluid can accumulate in the pleural space due to chronic severe heart failure, and the clear fluid accumulation, known as a transidate, can cause a pleural effusion. An exudate is due to an infection or some type of inflammatory process, so it tends to be cloudy. This type of pleural effusion can occur secondary to a bad pneumonia, TB, pancreatitis, hepatitis, or a malignancy. Untreated, these infections turn into an empyema, which is pus. Whatever the cause, the outcome needs to be to do an emergent reinflation of the lung with a chest tube and figure out the reason later. The unintended outcome, besides a pneumothorax, is a tension pneumothorax, which is a medical emergency, as a mediastinal shift causes the airway to collapse as well as compression of the vena cava, resulting in decreased to no ventilations and a markedly decreased cardiac output. This picture shows you where the pneumothorax is located and the ultimate shift that can occur when there is no treatment. The skinny then is to have that negative pressure recreated, so the lung reinflates and fast. Whatever is causing the pneumothorax needs to be addressed as well. So if it has to do with a pleural effusion, concomitant treatment will be centered on that. In some instances, you may see a drain placed in the pleural space and connected to a chest tube, but not to suction, but used as a means to collect what is in the pleural space that is constantly accumulating. Instead of doing multiple thoracenteses, the drain is placed to gather the fluid. All seals must be maintained. As with any leaks in the system, the pneumothorax can reoccur. Here is an example of the system itself. It is meant to be a closed system. You do not empty this unit. If all of the collecting chambers fill, you need to change the whole system. Let me go through this chamber by chamber. The suction control chamber has sterile water or saline added to it by the nurse as the system is being set up. The amount of fluid added depends on the physician orders, but typically it is filled to the -20 centimeter line mark. This determines the amount of suction added to the pleural space to evacuate what is in there. You would then apply suction to an outside wall source so that you have gentle bubbling of the water in the suction control chamber. You need to maintain the water level at the -20 centimeter mark, so a gentle, continuous bubbling is key. Next, this is the water seal chamber. Sterile water is also added to this chamber up to this 2 centimeter mark. The water seal allows air to exit the pleural space, but does not allow air in. There should absolutely be no bubbling noted in this chamber. If you see any after the initial evacuation of air upon insertion, it typically means there is an air leak somewhere in the system. And finally, there are the collecting chambers. After the first 24 hours, where drainage is measured hourly, Every 8 hours, the level of drainage needs to be clearly marked with a Sharpie to be able to follow total drainage. There should not be more than approximately 75 milliliters that drains per hour, especially if the drainage is bloody. If so, this needs to be reported to the healthcare provider immediately. Unless an emergent procedure, consent is required as this is invasive. If not done so at the time of consent by the healthcare provider, explain to the patient that this procedure will assist their breathing and that they will feel better post-procedure. Obtain a thoracotomy tray, which has all of the equipment needed for insertion except for the chest drainage system specific to your hospital facility. This tray also contains a local anesthetic, but the patient should also be given an IV sedative or pain medication prior to insertion. While the healthcare provider is getting their equipment ready, it is the job of the nurse to set up the chest drainage system. The patient is typically positioned on their unaffected side laterally, supine, or semi-Fowlers. Remain at the side of the patient's bedside during insertion, as this procedure is very scary for them and they typically are suffering from respiratory distress. Keep watch of the pulse oximeter and the need to adjust oxygen concentrations as needed. I think these are great pictorials of exactly where the tube is placed in the pleural space. If the tube is collecting air, then it typically will be placed higher in the chest, whereas if draining fluid, then lower in the chest. Air rises in the pleural space, where fluid falls due to gravity. Nurses need to be vigilant in their assessment skills post-chest tube insertion. Immediately following insertion, a stat chest X-ray is ordered to assure the lung was re-expanded post-procedure. Vital signs, including a pulse oximeter and pain assessment, needs to be conducted at least every 4 hours minimally. It is important that you monitor the water seal chamber for an air leak because you desire a completely closed system. For the first 24 hours, the drainage should be measured every hour and then every 8 hours following the first day. The chest drainage system must be kept below the level of the chest, as you don't want drainage moving back into the pleural space. The system should be free of kinks. And while the tube is in, titling should be noted in the water seal chamber and tubing as the patient inhales and exhales. That is just the fluid level going up and down in line with respirations. These patients are prone to pneumonia and atelectasis due to splinting their respirations secondary to pain. So aggressive pulmonary toilet needs to be done, but after pain medication is administered. Patients with chest tubes are much more likely to cooperate with the plan of care if you relieve their pain. If the drainage coming out of the tube suddenly gets cloudy or suddenly with bright red blood, contact the healthcare provider. Monitor the insertion site for signs of infection, and by all means keep the system from the insertion site down to the drainage system secured and all dressings tight. You do not want an air leak. I am going to reinforce these are the do not do's. Nurses in the olden days used to strip or milk the chest tubing if there was a bit of tissue or a blood clot that partially occluded it. All we were doing was increasing the pressure in the pleural space and not doing our patient any favors. Unless there is no other option, the tube is never to be clamped. Patients with a chest tube will probably find every reason in the world to stay in bed because having a chest tube is painful and unruly. These patients can and must get out of bed. While connected to suction, they have to remain close to the bed, but they can get out of bed and sit in a chair. The best position for them is upright, as it assists with optimal ventilation and therefore oxygenation. It is very easy for these patients to get atelectasis and pneumonia due to the pain of breathing. Oh yeah, and don't ever disconnect the suction until there is an order to do so. Dependent loops hold drainage in them, but you want the drainage to move into the collection chamber. It is suggested that the tube be coiled on the bed or put the drainage system close to the bottom of the bed to straighten the tubing and facilitate drainage. And the drainage system needs to be upright to maintain the closed system and prevent air leaks. So don't knock it over. This is what the site looks like without a dressing. There must be a dressing on the site at all times unless you're changing the dressing. The tube is usually sutured in, but that doesn't mean it can't be pulled out, so be careful when you do turn the patient and get them out of bed. The insertion site needs to have an occlusive dressing, and all connections need to be tightly secured. One complication of a chest tube is an air leak that gets into the mediastinal space and surrounding tissues. This is called subcutaneous emphysema, or you may hear the word crepitus. It is an interesting feeling on the tips of your fingers during palpation, as you feel the small air bubbles popping on the tips of your fingers. Air is going to rise, so you may palpate crepitus in the chest wall itself, under the armpits, in the neck, or even in the face. Again, try to prevent leaks in the system. These are just a few examples of how these patients look. There are two big complications with chest tubes. First, the possibility exists that the tubing can become disconnected. You are to ask the patient to exhale as much as they can until you can put the end of the tubing into a few inches of sterile water. This equipment needs to be by the bedside at all times while the patient has the chest tube in place. This maintains the water seal until you can set up a new unit. Also, the chest tube can be pulled out accidentally. If this happens, quickly cover the site with a non-porous, sterile petroleum gauze, sterile dressing, and occlusive tape. Call the healthcare provider immediately. A chest tube is ready to pull when the lung remains inflated off suction and there is minimal drainage. When it is time to pull the chest tube, typically within 2 to 5 days of the occurrence of the initial pneumothorax, make sure your patient has been pre-medicated. This is a painful procedure for them. Place them in a semi-Fowler's position. The sutures surrounding the tube will be removed by the healthcare provider. Most research suggests that at the time of removal, the patient takes a nice deep breath and holds it as the tube is being removed. That will prevent air from entering the insertion site to decrease the chance of the redevelopment of the pneumothorax. Other sites suggest the tube gets pulled during expiration or with a Valsalva maneuver. Regardless, the most important step is for the healthcare provider to quickly apply petroleum gauze and an occlusive dressing that you do not remove. Some patients have pull string sutures that will be tightened prior to the dressing application. A chest X-ray post-removal must be done. Careful respiratory assessment by the nurse is key at this time. So what is our outcome? A lung that remains inflated, with good ventilation and oxygenation, with a good pulse oximeter reading, normal heart rate, and respiratory rate. This concludes the presentation. If you have any further questions, please don't hesitate to contact your instructor.